Well, welcome back, everyone. I hope you had a good time looking for your prize to follow tomorrow morning, perhaps tomorrow afternoon, depending on where you're at. So, we're coming back now to a different but related topic: expert perspectives, best approaches to diets for cardiometabolic health. And our first speaker is Dr. Kim Allen Williams, who ultimately is a past president of the American College of Cardiology and currently is the James B. Herrick Professor and Chief of the Division of Cardiology at Rice University Medical Center. He's also the Associate Dean for Faculty Diversity, Equity, and Inclusion, something we heard a lot about yesterday. So, Kim, it's up to you to approach our first topic this morning, which I think is going to be based on plant and vegan types of dietary approaches for cardiometabolic health.
Thank you, Bob. I really appreciate it. It's good that my reputation precedes me, and I'm sure we'll have a robust discussion about it. But I always say that it's really not a good idea to talk during a pandemic without addressing the pandemic. And sure enough, cardiometabolic issues have come to the forefront because of the presence of diabetes, hypertension, obesity in the people who are dying of COVID. So it really is an amazing synchrony between cardiovascular health and COVID mortality. People have rightly identified that when you have a population such as African Americans and even Hispanics who have a lot of cardiometabolic risk factors, they end up with more, there's more of a disparity in death than you would expect. And sure enough, people have seen that, yeah, if you're African American, you die from COVID so much faster. But if you look very carefully at the data, which is published in the New England Journal of Medicine and reproduced in Rush at our place, it turns out that Black is not a risk factor for dying. It's having risk factors that are out of control, the obesity, the high cholesterol, and the like. And so I'd like to talk about the fact that we are in the middle of a pandemic, inside of a pandemic. We've had heart disease be the leading killer of Americans since 1918, when it was taken out for a year by the Spanish flu epidemic. And now we thought COVID would be the number one in 2020, but it turns out it wasn't. It was cardiovascular disease again. And everything that we've done to try to lower it has helped, but it hasn't helped everyone. We still have this ethnic disparity, which you guys have focused on yesterday. And so, but even among these fantastic improvements in cardiovascular mortality that we've had over the last 40 years until about 2015, when it stopped and started to plateau and go up again, we still were doing pretty much this with advances in cardiology and advances in cardiac surgery and the like, instead of really turning off the faucet, instead of just developing better mops to mop off the floor. So we've continued to struggle with nutrition. We have a growing epidemic of obesity, and as well as the risk factors of hypertension, dyslipidemia. For that reason, we have tried really hard at the American College of Cardiology, American Heart Association, to focus on primary prevention and to try to get people to focus on removing those risk factors and focusing on diet and exercise. And if we could get people to do that, we would improve dramatically. We have really good data that the risk factors do affect not just cardiovascular health, but COVID mortality, the body mass index, smoking. These are the issues that make COVID much more severe. So what can we do about our obesity epidemic? Well, one of them, obviously, this is a nutritional issue. We have clear-cut data that our obesity leads to more mortality, that 3.68, not just obese, body mass over 30, but just a body mass over 25 increases your risk. Why? Well, there's a lot of immune mechanisms that everyone has identified, including the adipokines that are excessive and reproduction of the cell inside adipocytes. So people do need to lose weight for their cardiovascular health, is also to avoid COVID illness. So it turns out that we have nutritional challenges. We have the big meals, high calories, not enough fruits and vegetables. Very sorry to see this published a few weeks ago, saying that 90% of Americans are not doing the 2 to 3 cups of vegetables. But when we talk about obesity in the United States, we have to admit that it's not evenly distributed. This is the number of states with obese more than 35%. In dark, this is the white population, not nearly as bad. This is the Hispanic population, a bit worse, but the African American population is even worse. And so when you're talking about, hopefully, when you're mentioning your socioeconomic disparities, you have to mention the fact that there are food deserts, and there are people on the south side of Chicago where everything that's close to them is a fast food restaurant. And that really does make it difficult for us. We have dietary interventions, and I'm sure people on this discussion today will be supporters of low carb, vegan, anything that lowers the calorie intake will improve this. I mean, you could argue from some of the published data that the more vegetarian you are, the more sustainable it is, but there's no question that we need dietary intervention, a lot of education, and that will help us with the obesity epidemic. If I move over to diabetes and hypertension, the relationship to diet is very clear, and we have large observational studies where you have multiple kinds of diet, and the one that is consistently not obese or overweight is the people who are doing completely plant-based or predominantly plant-based nutrition. It does correlate with an improvement in mortality as well, and that is something that we have to recognize because it helps so much. We have similar data for blood pressure that has gotten a lot of press. Sure, there are occasional studies where you go vegan and the blood pressure goes up, but the vast majority of the data, the preponderance of the evidence is that a more plant-based intervention will do what you saw in the DASH trial. When you do a low sodium approach, more vegetables, and you eliminate the fat and the cholesterol, which means more of a vegetarian diet, you get a more dramatic decrease in blood pressure. So this is actually part of our guidelines: more physical activity, less alcohol, more plant-based nutrition to lose the weight, keep the sodium down, keep the potassium up. And if we do that, we are going to be much more successful in decreasing the blood pressure epidemic that we have in some of our communities. If we talk about, I want to talk about sugar for a moment, because we have a relationship with sugar that we have to understand that all of us, vegans who are eating sugar are actually worse off in many ways than people who are eating animal products. And so if we look at Nurses Health Study, what makes the nurses die, it isn't just aging and smoking and diabetes. It actually is the preponderance of glycemic load, which is worse than an animal load, at least numerically, if not statistically, and neither are as good as doing vegetables. And so we really shouldn't be doing a lot of excessive sugar. If we do, we definitely will see the increase in mortality. We have to actually talk a little bit about not just sugar consumption in sweetened beverages, but also artificial sweetened beverages. Some of the data says that artificial sweeteners are not quite as bad as sugar, and this particular article published recently says that it's actually worse. And so the high consumers end up with more mortality. Is there an association between diabetes and people are coining the term diabesity? No question about it that if you're doing a plant-based diet, you will see a significant lowering of the amount of diabetes. It's a linear relationship between how plant-based you are, which is interesting because obviously keto diets, which I'm sure we'll hear about from Dr. Hallberg, will lower your diabetes as well. But in terms of if you're looking to do a cardiovascular, which every cardiologist is interested in, improvement, lowering the cholesterol, substantially lowering inflammation, you would want to do a vegetarian diet for the glycemic control. And if you do that, you will see data like this, where the more vegetarian you do, the lower the blood sugar is going to be. And so if I move on to talk about dietary fats, because you see a lot of stuff saying that saturated fat is back and it's good for you. The data from American Heart Association, Nurses Health, all of them say about the same thing, that saturated fat increases mortality, increases cholesterol. Monounsaturated fat, polyunsaturated do the opposite. And I know there are plenty of vegan diets out there that say you shouldn't do any fat at all. I'm not sure that that's particularly evidence-based, because monounsaturated and polyunsaturated fats seem to have a benefit. Is it substitutionary benefit? Like it's possible that just getting rid of the saturated fat is what's really helping. If I move forward to talk specifically about carbohydrates, this is the PURE trial showing that when you're doing a lot of countries, the more carbohydrates you are able to substitute with other items, the lower the mortality is going to be. And there's no question that buried in the methods is that they were talking about refined carbohydrates. And so it turns out that fats really are better than refined carbohydrates, but certainly probably not as good as complex carbohydrates with the high fiber. And so we do have much more in the way of cholesterol and inflammation data than we used to have. I have to include the fact that that COVID uses cholesterol as a transport protein to get into the cell. And so the higher your cholesterol, the higher your viral burden. And if we look at cholesterol content of food, you will see very interesting that obviously the plant-based items don't have substantial amounts of cholesterol. And there are some animal products that don't have cholesterol, such as egg whites. Unfortunately, our population tends to eat egg whites with egg yolks. If we do a dietary intervention, and one of the first to show this with C-reactive protein and cholesterol was actually David Jenkins and the plant sterols. I know that has a checkered history, but more viscous fibers, soy protein, and almonds. It turns out that this is highly successful at lowering LDL cholesterol and C-reactive protein in a manner that's similar to what happens with a statin. So we have the more data published a couple years ago from Benita Shah's group, the EVADE CAD trial, showing that the plant-based approach for cholesterol, LDL cholesterol, and for inflammation is going to be superior. So to summarize that part of it, we have really good data that the more plant-based you are, the lower the cholesterol is going to be. There are a handful of outliers, but for the most part, it's pretty clear that when you lower your ingested cholesterol, you lower the serum cholesterol. I want to talk just for a couple minutes about dietary patterns. The one that is, you can argue which one is better, which one is worse, but one is very clear from the Regards trial is that the kinds of food that we tend to eat in our African-American community, where I grew up on the south side of Chicago, the so-called Southern diet is the worst. It has a lot of sugar, a lot of saturated fat, fried foods, putting sugar in vegetables and meat in vegetables. And the higher risk of heart disease, kidney disease, and stroke is very, very clear. If we then look at the problem that we're having with our vegan colleagues, eating a lot of refined carbohydrates, frying the potatoes, it's very similar. You end up with this dotted line shows a worse mortality than what you would get if you were eating animals. I do want to spend just a minute talking about keto diet, and we'll learn a little bit more from Dr. Hallberg, I'm sure. The reason it became popular was because it actually works in terms of weight loss. The problem has been, and this is something that I've not been able to answer, looking at all this literature, that is the Greeks. Showed an 22% increase in mortality. The Japanese, very similar. That was more like a 31% in mortality. The one from the United States, the ERIC trial, showing an 18% increase in mortality. And it turns out that if you do that with plants, you don't get that 18% increase. And the more keto you are, the more mortality there is. But the question that I have from all of these studies is how long can you do it? Obviously, you would never want to do it in someone who's post-myocardial infarction, because that 53% increase in mortality is quite a bit. But if you look at glucose homeostasis, it's beneficial. If you look at lipid homeostasis and inflammation, it's not. And so those increase in inflammatory markers, despite the fact that a number of metabolic parameters get better, the HDL going up, we know now that that doesn't help from Canhart and from Copenhagen. Higher HDL can increase myocardial infarction. So increasing HDL and LDL is not as good as we thought it was in the past. And so we have sort of a final word from the National Lipid Association saying that this is really something that we shouldn't do, because despite the increase in HDL, the increase in inflammation is going to be not beneficial. So in my last minute or so, I don't want to spend too much time talking about eggs or specific components of the keto diet. Each one of them has been independently associated with mortality, and you could poke a lot of holes in the way these trials or these observations are done, but there's a lot of them saying that eggs and in different countries, red meat, particularly processed red meat, that is dose related, that they all increase mortality. But if I had just 30 seconds left, I would say that the one that I find most frustrating is this one, and that is the Mediterranean diet, where people will over and over talk about this wonderfully done prospective trial showing a 30% decrease in heart attack, stroke, and death. and not realizing, even though it was published by the authors and reviewed and published very well in New England Journal of Medicine, that it does not save lives in primary prevention. It did in secondary prevention, but not primary prevention. And so what's wrong with it? Well, it lowered, for a cardiologist, it's not good. For a neurologist, it's very good. Switching from red meat to fish seemed to decrease stroke dramatically. Myocardial infarction did not change, cardiovascular death didn't change, and death from any cause did not change. So not something for cardiology. However, if you turn the data on its head and look for when they published the pro-vegetarian food pattern, it actually showed very well that there was a 42% decrease in mortality if you did a plant-based Mediterranean diet. In closing, I want to talk about just the two things that I think are driving all this data. Number one is trimethylamine N oxide. You don't get it from plants. You get it very little from white meat. You get it a lot from red meat. It's associated with myocardial infarction, heart failure mortality. And the more TMAO you have, the more heart failure you have, the more kidney failure you have. And so it has to do with processed meat, has to do with consuming meat. And the last portion that I'd like to focus on is the whole idea of the microbiome. So the microbiome is driving the TMAO level up. And if you do an analysis of the gut microbiota, the cytokines and inflammation associated with COVID-19 are actually responsible for the bad outcomes. It has to do with the microbiome. Should be taking over whatever we think about diet, neurology, cardiology. And one thing that's very clear is that the vegetarian and vegan diet can actually improve the microbiota in a way that will stop the development of chronic kidney disease, heart attack, stroke, and mortality. So I'm going to stop right there because that is exactly 15 minutes as I calculate it. And I'm hoping to hear and learn from the other speakers.
Great, Dr. Williams. Thank you very much to get the ball rolling in the right direction or perhaps a different direction. So we're going to turn now to Penny Kris-Etherton. Penny's a longstanding colleague and friend from Penn State University, where she's the Evan Pugh Professor and also a distinguished professor of nutritional sciences. Penny, you're going to address the issue of dietary patterns. Please go ahead.
Thanks so much, Bob. Well, we do have new dietary guidelines, and they represent a total dietary approach, i.e. a healthy dietary pattern for promoting health and preventing chronic diseases. So that's what I'm going to focus on today, a total diet. We know that poor diet quality is a major risk factor for all cardiometabolic diseases, and the US diet is very poor. What defines diet quality is many factors, and I want to talk about those because that means that we have many targets for improving diet quality and decreasing risk. And then improvements in diet quality benefit cardiometabolic risk big time. Even small changes have big benefits. And then we'll talk a little bit about strategies for helping patients improve diet quality and sum it up. Well, Dr. Williams noted that cardiovascular disease is the leading cause of mortality in the United States and actually globally. It's been like that for a long, long time. Diabetes and chronic kidney disease are number 2. Diet risks are number 1, and they've been number 1 for a long time. So there's a lot we can do with a healthy dietary pattern. Now, it's also important to note that risk markers for cardiometabolic diseases are affected by diet as well. So the risk markers affect cardiovascular disease, and we can do something about high blood pressure, high blood cholesterol, high BMI, and high blood glucose with a healthy diet. What are the new dietary guidelines? Well, they're shown on this slide. Follow a healthy dietary pattern throughout life. Customize, though, and enjoy nutrient-dense food and beverage choices to reflect personal preferences, cultural traditions, and budget. Focus on meeting food group needs with nutrient-dense foods and beverages and stay within calorie limits. And what's really important is watch those nutrients and foods to moderate, added sugars, saturated fat, sodium, and alcoholic beverages. And the byline is so perfect. Make every bite count. And what we see is that if people follow current food-based dietary recommendations and meet these recommendations, they will get 85% of their calories from nutrient-dense foods. That means they only have 15% of their calories left from added sugars and saturated fat and alcoholic beverages. There's not a lot to play with. The 2020-2025 dietary guidelines made recommendations for 3 healthy eating patterns, and it's just a healthy US diet, a healthy Mediterranean style diet, and a healthy vegetarian diet. And if you look at the specific servings of different food groups recommended, you're going to see they're very similar among these 3 diet patterns. They're rich in vegetables, fruits, whole grains, low-fat dairy, and you can see specific protein food recommendations and liquid vegetable oils. For the vegetarian pattern, I've pulled out the protein foods that are recommended, and we do know that this diet can be made to be vegan as well by swapping out animal-based protein foods like eggs and dairy products for plant-based sources. This slide shows, again, how poor Americans' eating patterns are for specific food-based recommendations. So you can see that the blue lines going down basically show, the percent of the population below each dietary goal. So we're not eating the recommended amounts of vegetables, and then fruits, and then whole grains, and dairy products is way low. And then with the last 2 bars, seafood consumption is way low, and plant protein foods are way low. So basically nuts and seeds. So we have a lot of work to do to improve diet quality. And we see here, Americans are eating way too much added sugar, saturated fat, and sodium. And this slide basically shows the percent people exceeding limits of added sugars, saturated fat, and sodium. And the one that's most remarkable is sodium. Hardly anybody, 97% of men in the US are not meeting sodium recommendations. But across the board, over 50% aren't meeting current dietary recommendations. When we look at diet quality, and this is a measure of the total diet quality based on current dietary recommendations, we see that it does vary a bit between different population groups, but notably, we all fall way short of achieving the goal of 100. So lots and lots of work to do here. We have seen some improvement over the years in diet quality. The average diet quality in the US is 59 points out of 100, but boy, we haven't made much progress at all. We're eking up by teeny tiny little steps, which is better than going backwards, but still long way to go. And then if we look at how American Heart Association defines diet quality, what you can see here in the middle of the slide is less than 1% of the population has a green bar. And so it's really showing that diet quality, even more than all these other health factors, is the worst of all. And when we look at diet quality in different ethnic groups, what we see here is that Hispanics and non-Hispanic Blacks at every single age group have more red bars than any other ethnic group. So this is a group especially that needs a lot of work. Okay, let's talk about diet quality now. And it's measured a lot of different ways. One common way is Healthy Eating Index, and there are 13 different foods and nutrients that are scored. They're listed on this slide here. And we have nutrients that we want to promote, and then foods and nutrients that we want to moderate. And those are the refined grains, sodium, added sugars, and saturated fats. And that's what adds up to a score of 100. But there are other diet quality assessment instruments out there. And they're basically all the same. You know, they score on the foods that we want people to eat more of and take points away for the foods and nutrients that we want people to eat less of. So there's a lot of research now. Sorry about this, everybody. Basically showing benefits of high diet quality on cardiometabolic risk factors. Here's one systematic review and meta-analysis. They looked at adherence to a healthy Mediterranean diet, a DASH diet, a vegetarian diet. And you can see here that adherence to the Mediterranean diet decreased cardiovascular disease incidence and mortality. Adherence with the DASH dietary pattern improved cardiometabolic risk factors and incidence of CVD. And a vegetarian dietary pattern had many benefits: cardiometabolic risk factors, coronary heart disease incidence, and mortality. And what we see here is, you know, this is the same paper, just looking at risk markers relative to Mediterranean diet, you know, all beneficial associations here and effects. And also benefits of the DASH diet on blood pressure, total cholesterol, LDL, glycemic control, and body weight. And you can see vegetarian diet benefits as well. Now, as we talk about a plant-based diet, it's so important that it be a good quality plant-based diet. So Kim mentioned this. The Harvard investigators have done some really good work. And basically, an unhealthy plant-based diet does increase risk of coronary heart disease, as you can see here on this slide. But a healthy plant-based diet shows benefits. So for all these teenage people, kids who are on plant-based diets, eating French fries and cola beverages, that's not the definition of a healthy plant-based diet. What we see in this slide here is benefits of increasing diet quality on a Mediterranean diet and decreased risk of diabetes. These are data from the ERIC study. Very beautiful relationship with improved diet quality and decreased diabetes risk. In the WHI, a higher healthy eating index score showed lower risk of all-cause death and lower risk of cancer death. So that's, you know, another disease as well. So across the board, we're seeing benefits of total diet quality on cardiometabolic disease, risk markers, and other diseases as well. And so high diet quality is inversely associated with risk of all-cause mortality, cardiovascular disease, incidence mortality, cancer incidence and mortality, in type 2 diabetes, also neurodegenerative disease. And this study done on cancer survivors. So again, more and more benefits. Now, this is what I think is really exciting. And that is, these are the Harvard investigators who used, 3 different markers to assess diet quality. And they looked at, all their prospective cohort studies and basically showed that small changes, a 20 percentile increase in diet quality score, reduced risk of death from any cause. And that's really of such an important point, because going back to the dietary guidelines that say a healthy dietary pattern at any stage is important. But even if people start midlife, they will realize benefits. And then likewise, the Harvard investigators showed the same thing in this study that came out in JAMA in 2020. If you look at the far right, basically a 25 percentile increase in diet quality was associated with benefits from cardiovascular disease, coronary heart disease, and stroke. And there are also benefits too in improving diet quality on age-related increases in body weight. You can see that in this slide too, that people who increased their diet quality the most basically had the lowest age-related increase in body weight. So there's a lot we can do by improving diet quality. And there are a lot of different ways that we can improve diet quality, lots of different targets there. So in terms of the prevention guidelines, a team-based approach is really important. Talk about that in just a minute. Shared decision making is really important. And then social determinants of health. So in terms of shared decision making, what are those diet targets going to be? And in terms of social determinants of health, many people are going to need additional assistance in achieving target goals. So there are rapid diet assessment tools that you can use in clinical practice. This article just came out from American Heart Association on assessing diet quickly in clinical practice. And you can see here, there are 2 rapid diet screeners that I presented on this one slide. One comes from the presentation that Dr. Eckel gave at his presidential address when he was president of American Heart Association. So take a look at these, because you can just quickly get some assessment of diet quality and then go back and figure out what targets they're going to be. You're going to advise after you've assessed, and then agree with your patient on certain goals. And the goals should be SMART. They should be specific, measurable, achievable, realistic in time. But then your patient's going to need some assistance after that, especially people who may be having some budgetary problems. They're really going to need help in finding resources to help them achieve their SMART goals. So in summary, higher diet quality decreases risk of cardiometabolic diseases. There are attainable changes. Somebody doesn't have to change the whole diet, but small changes can have big effects. And there are many different targets, which is wonderful. It really sets the patient up for success. And finally, advice for helping patients to improve diet quality. Shared decision-making is key. Use the 5 A's, and by all means, set SMART goals. And with that, I thank you very much for your attention.
Great, Penny. Thank you very much for this different perspective. And now for a third perspective, which, by the way, there's going to be a lot of overlap between these various approaches. So I think we need to take that into consideration when we approach the patient, challenging patients to discuss after Sarah's presentation. Dr. Sarah Hallberg is the director of Virta Health in San Francisco, California. And Sarah, your topic is one of a smart way to reduce carbohydrates in the diet to improve cardiometabolic health. Sarah, you're on.
Thank you so much. I am very glad to be here during this panel today. Oops, let me see, start, okay. And with my esteemed colleagues, and I want to thank the coordinators of this conference for asking me to join today. First, I want to go over my disclosures. I think the most important disclosure here for me is an intellectual bias. I have been recommending and counseling patients with type 2 diabetes to follow a carbohydrate restricted diet for almost a decade. And I like to say, once you see this in real life and see the changes that it can make in someone's life, you just can't unsee it. For today, we're going to try to cover a lot of topics due to time limitations. I'm going to be breezing through some of the studies as our other speakers have, because we're so tight here, but my slides will be available to anyone who wants them. I'm going to skip over this one because it's already been discussed. Cardiovascular disease rates are plateauing, or disease deaths are plateauing concerningly in this country. I think most people realize that it's due to our other epidemics that have been around longer than COVID, which is diabetes and obesity, and just how much of a risk factor are metabolic diseases, including insulin resistance, prediabetes, and diabetes when it comes to heart disease. Well, this 2009 study from Diabetes Care actually looked at a mathematical modeling in a number of different risk factors and came up with insulin resistance as the most significant risk factor for coronary artery disease. And the top line here that is solid is insulin resistance that is not treated. The dashed line below it would be insulin resistance that is treated. treated. And what we see is a dramatic decrease in the incidence of MI. So the study concluded that insulin resistance is the single biggest risk factor for coronary artery disease. This is an interesting study out of China that was recently published, over 14,000 participants. Starting the study with prediabetes. Prediabetes is the green line here in the middle, and looking at what would happen over time if people progress to type 2 diabetes, which is the blue line right above it, or if they actually reverted to normal glycemia, which is the red line. And whether it's cardiovascular disease or all-cause mortality, reverting back to normal glycemia has a significant impact on mortality. So one of the things I think we can all agree on is metabolic disease is a major, if not the most important risk factor for cardiovascular disease. So why do I think therapeutic carbohydrate restriction is the best lifestyle intervention for this? Well, there's a number of reasons that I'm going to try to cover here. First, just a very quick basic science slide out of Nuttall and Gannon from University of Minnesota, looking at a standard American diet, which if you look at the macros is essentially the same as the dietary guidelines. Postprandial excursions, not unexpected here, compared to a very low carbohydrate diet, actually lower than what I recommend, because we want to ensure all of our patients get 5 servings of non-starchy vegetables per day, but noticing that it's almost at fasting levels when it comes to those excursions and drop in blood sugar. When it comes to hemoglobin A1C, because I don't have time to cover the many, many studies there are that show this, I do want to point out this recent systematic review from the BMJ, noting 2 things. Number one, that they defined low carbohydrate diets correctly, and I'll come back to that in a minute. But also when it comes to hemoglobin A1C, what we have is a high level of grade evidence showing that when it comes to hemoglobin A1C, it favors a low carbohydrate diet over controlled diets. Next, when it comes to hemoglobin A1C, I want to touch on a trial that I am just wrapping up. Next week is the end of our 5-year data collection, which we hope in this trial will be published by the end of the year. It's a prospective controlled trial. And I want to point out really quick sustainability, which is often noted as a concern. And there's absolutely no evidence that shows that a carbohydrate restricted diet is any more difficult, in fact, likely easier to sustain in the long run than other dietary patterns. In fact, we had 83% retention at 1 year, 74% retention in 2 years. So were they still doing what we asked them to do? Actually, instead of having to rely on what we know are, very faulty dietary records, we actually had a biomarker. And so we checked beta hydroxybutyrate levels. And the interesting thing is beta hydroxybutyrate levels here at this 1 year point were exactly the same as they were at the 2 year point, showing that far out, patients were still following the dietary recommendations that we gave them. Not only were they just retained. So what we see here again at 2 years into our dietary intervention, we have a 1% drop in hemoglobin A1C compared to our control diet, which increased, which of course goes to the age-old thoughts about type 2 diabetes, which is it's a chronic and progressive disease, which I thoroughly disagree with. But again, it's not just hemoglobin A1C. We see a litany of metabolic improvements, again, versus virtually none in the standard care arm. And these outcomes, this is early data presented at Endocrine 2020, were sustained out to 3.5 years. But I do want to note this slide I'm really putting in here to begin the section on medication reduction, because what we see is a very swift medication reduction in the low carbohydrate arm. This is the control arm, and that extends all the way out to 3.5 years. And what we see here is also sustained improvement in both hemoglobin A1C and weight. Again, this is out to 3.5 years. Staying with medication reduction, it's important to see what the American Heart Association has to say about that. And what they say is that a low carbohydrate eating pattern is the one that can result in a reduction and elimination of medications. And when it comes to insulin and sulfonylureas, we know right away that that's an improvement in cardiovascular disease risk. Now let's talk inflammation. Of course, a critical part of all of our chronic diseases. Well, not only do we have a robust literature on the clinical improvements in inflammatory markers with carbohydrate restriction, but we actually understand the basic science of this. We know not only does it show up clinically, but how and why it works. And it all boils down to beta hydroxybutyrate. And it turns out beta hydroxybutyrate is actually a potent anti-inflammatory agent, and it acts to suppress oxidative stress through histone deacetylase inhibition. It also acts directly on the NLRP3 inflammasome pathway to decrease inflammation as well. Now on to the really fun to look at the clinical trial data on this. This is a study out of Jeff Volek's lab looking at 3 months of a low carbohydrate diet versus a low fat diet, looking at 14 different biomarkers of inflammation. What you see here is 7 of those biomarkers significantly decreased in the red, which is the low carbohydrate arm. 7 of them didn't differ between groups, but what you do notice is not a single one improved more on the low fat arm. Next is an early look, again presented at Endocrine 2020, of our study data. And what we see here is very significant and robust decreases in a litany of inflammatory markers in our diabetes population, which is the top left, pre-diabetes population, which is the top right. And again, when we look at the standard of care, we don't see any significant improvements in those inflammatory markers. So, quite significant data. Next, I want to talk about hepatic fat, and I want to bring up this really great study from Iris Shay's lab in Israel. She's done some really great work with a Mediterranean low-carb diet, and here is just one of those studies looking at hepatic fat concentration with a low-carb Mediterranean arm versus a low-fat arm at 18 months. We see significant improvements in hepatic fat in the low-carbohydrate Mediterranean group, of course, translating to decreased cardiovascular disease risk once again. Now, this is going back to the same study by Jeff Volek's group that we looked at before. And of course, we see all these improvements, but I really want to hone in on here is the decrease in serum saturated fat levels. Here we had a 3 times increase intake of serum saturated fat levels. Yet when you take dietary saturated fat levels. But when you take a look at the serum saturated fat levels, what you see is it's actually decreased in the lower carbohydrate, significantly higher saturated fat group. And that is because consumption of saturated fat taken in the total dietary matrix of carbohydrate restriction actually decreases serum saturated fat levels, which we know are associated with an increased risk of cardiovascular disease. Here's another study that showed many things comparing a low fat or a low carb, moderate carb, and high carbohydrate diet, but specifically looking at serum saturated fat. This is an interesting study, and actually they kept weight stable in all groups. But what we see here again is a decrease in the serum saturated fat levels, the top, in the low carbohydrate group. And what we see on the bottom true is a very concerning increase in the high carbohydrate arm of 16-1 or palmitoleic acid. Now, palmitoleic acid we know is associated with an increased risk of diabetes, inflammation, cardiovascular disease. This isn't really surprising because sterile palmitoleic acid is actually a product of sterile CoA desaturase, and its relation to a high carbohydrate diet and obesity has been well known for quite a while. Lastly, I'd like to touch on time in range, which is quite the rage now, but of course we know because there's data that it decreases cardiovascular risk. And I wanted to bring up this one of study looking at a low carbohydrate diet versus a low fat diet. Not surprisingly, when we look at time in range, much better for the low carbohydrate arm. Why? Because we're eliminating those postprandial excursions. Even before we had CGMs, we had this study, a metabolic ward study by Bowden, published in Annals in 2005. And here what they looked at is after only 2 weeks of carbohydrate restriction, this is ad lib, very low carbohydrate restriction, what we see is incredible flattening of both glucose and insulin. Another important thing is that insulin sensitivity increased by 75% as measured by a euglycemic clamp. And now I think I will move on to the change in the American Diabetes Association guidelines. So all these different guidelines have endorsed a low carbohydrate eating pattern, from the VA to the most recent standards of care. And when we look at the consensus report from the American Diabetes Association last year, what they have to say about carbohydrate restriction is this eating pattern does not appear to increase the overall risk of cardiovascular disease. What is a low carbohydrate diet? This is critical to my last point, which is why do we not see as much widespread use of this dietary pattern? And this is really important. Anything over 25% is not a low carbohydrate diet. Let me repeat, anything over 25% is not a low carbohydrate diet. But we get very concerning, not sincere discussion of the evidence when people constantly make the claim that low carbohydrate diets are associated with increased mortality. There's not a shred of evidence for this. Not a shred. I'm not talking a little, not a shred. Because when we take all the studies, what have claimed low carbohydrate diets are associated with an increase in mortality, which we see here, what we have is the average carbohydrate intake is over 41%. My friends, that is not a low carbohydrate diet. But it is very close to what Americans are eating today, which is between 45 and 55% carbohydrates. So I would say what we can sum up from those studies making those claims, which is very, again, misrepresentation of the data, what we can say is it is a lower end of what the standard American diet is today, maybe associated with bad outcomes. But we have to also remember that it's only based on prospective cohort data, which we know has its own problems and is correct when it comes to nutrition 0 to 20% of the time. Lastly, I want to go back to the study that I cited from the BMJ to say this is an example of how we use misrepresented diets, or misrepresented evidence to perpetuate some of the myths of low carbohydrate diets. I told you at the beginning that they actually did define low carbohydrate diets properly right here in the abstract. Yet in the conclusion, it says that there are studies suggesting the long-term low carbohydrate diets are associated with increased mortality. The study they cited for this, 37% carbohydrate intake. Once again, not a low carbohydrate diet. So the study contradicts itself within itself, and once again, perpetuating myths. I will end with this quote from Albert Einstein: to raise new questions, new possibilities, to regard old problems from a new angle requires creative imagination and makes real advances in science. Let's not bang our heads against the wall anymore, and let's take some real action and see some real changes in the metabolic disease pandemics that we face today. Thank you so much.
Well, great, Sarah. Thank you very much. I think we all need to use some creative imagination as we approach our patients in terms of dietary prescriptions. So let's see if we can sort some of this out, these differences in approach to our patients and their prescriptions for dietary intake, and begin with a case. Kim, I think you've got the first case up. So as soon as you post that, we're ready to go. And we're going to have 5 to 6 minutes of case presentation with about 10 minutes to follow in discussion for each one of these. So please go ahead, Dr. Williams, when you're ready.
Sure, just taking myself off of mute and hiding behind the no camera and getting back to where we are. So so I asked for a case report. I just pulled the most recent referral to me, who was someone who at the time that the cases were asked for, And it's so typical of what I see in the inner city. Referred to cardiology, 54 years old, for abnormal stress test done for right arm pain, which is probably not cardiac in any way. Aware she's had hypertension, dyslipidemia, obesity, positive family history of sudden death at a young age, but with sudden death, and no one knows exactly what the what the etiology was. Denying any chest discomfort, dyspnea, palpitations, or syncope, but admits that she doesn't exercise much due to her orthopedic-ish limitations. She's been on been prescribed medication for hypertension and hyperlipidemia, but she is forgetful and admits some non-adherence. She has been on lovastatin, which, as everyone knows, is our weakest statin. Only took 2 of the pills. Really an issue of memory, not an issue of statin-associated muscle symptoms, which is so common. Not doing an exercise, as I mentioned, and she's on a general American diet, and does not do the home blood pressure monitoring that we have promoted in our 2017 hypertension guidelines. So if you look, she has had a history of hyperlipidemia, with an LDL greater than 190, which does make her a possibility. Instead of 1 in 500 or 1 in 250, makes it more likely 3 or 4% likelihood that she actually has heterozygous familial hyperlipidemia. The obesity and other issues I've mentioned. The physical exam, notable for slightly above optimum pressure, but we do not believe office pressures. Not just because of office hypertension, but also in our inner city. Most people are not aware of masked uncontrolled hypertension. If you're not familiar with that, please look at our 2017 guidelines, where the blood pressure in our inner city people can be 30 millimeters lower in the office than it is at home. She does have a loud fourth heart sound, suggesting that she has diastolic dysfunction. Her LDL has been really poorly controlled over a long period of time. And it's important to try to make an impact in that, because these greater than 190 really is an indication by every lipid guideline to go ahead and treat immediately, so we can lower the area under the lifetime LDL curve. If we look at the testing that she's had, she did have SPECT perfusion imaging. She had an ischemic fraction of 12%. I know knee jerk for most cardiologists is to take anybody with 2 vessel ischemia and maybe even 1 vessel and go to coronary angiography. We really try not to do that, because we don't have any evidence that it improves outcomes in a person who isn't symptomatic if the ischemic fraction is less than 13%. So I try to normally SAVE people, which is a statin, my little acronym for statin, aspirin, a vegetable-based diet, and an exercise program if we can do it. And she is supposed to be on hypertension medicine. We had long discussions, and this is really about counseling the patients as best we can, and getting her to understand that with that LDL greater than 190, we need to do several things. One is to control the cholesterol intake. Another is to take the statin, to do the exercise program. And I'm a big believer, particularly with the British experience, of doing the cascade testing. She consistently has an LDL greater than 190. Every primary relative, parent, child, sibling, really needs to be tested as well. For her obesity, I'm not one of the folks who routinely recommends the Esselstyn diet, even with half a parentheses. The issue is that, that whole idea, the fat you eat is the fat you wear. There's some truth to it, but restricting carbohydrates, particularly refined carbohydrates, will have its benefit as well. I think the one issue with the Esselstyn diet is the lack of nuts, where recent data published by Dr. Hugh she's actually at Rush now, consistently, if you're not making a nut butter, nuts consistently show a decrease in weight. So that is my typical case. It encompasses what I see every day in the cardiology clinic, coronary disease with multiple risk factors, trying to do as much as we can to help with the lifestyle as well as medications.
All right, Kim, thank you very much. So this case is open for discussion. So let's begin with her LDL cholesterol, because I think that's her major risk that you've described. By the way, what was her body weight? Did I miss that?
So, yeah, so 254 so a body mass index of 42.
Yeah.
Dr. Eckel, could I interrupt? Because the one thing that I noticed when we talk about her biggest issue is I'm not sure that we know for sure her biggest issue, because one of the things that wasn't pointed out here, but I presume that Dr. Williams, is what her racial background is. And I think that that's really important, because looking at her lipids here, this to me says African-American lipids in many ways, not necessarily. It can certainly be that way in a Caucasian, but if it is an African-American, then I would say, we need to know what her glucose is, because typically African-Americans can present with normal triglycerides and HDLs. And it's one of the things that we as a medical community often miss, is just checking lipids and then missing the glucose that goes along with it, which would definitely be a factor in her dietary recommendation.
So thanks for that. I thought I mentioned that she was African-American. This is one of those old things where, I think it was California, they passed a thing saying you're not supposed to put the race of the patient now.
Yeah, right.
The exact opposite. It is, you're so right. It is so important to understand what the increased risk, and Bob Eckel and everyone who published the 2013 guidelines with a risk calculator that finally takes into account African-American heritage, or self-identified African-American. So thank you for that. And yes, she remarkably, I'm sure she has skyrocketed insulin levels to maintain her hemoglobin A1C, but her sugars are actually normal, which I don't suspect that that'll happen forever, because you just can't sustain those insulin levels that long. But good points were made.
Well, Sarah, I'd like to politely disagree with you a little bit. I think her race has nothing to do with her LDL cholesterol, and her weight.
Well, no, I'm not saying it, and that clearly needs to be addressed. Well, I'm not arguing with that at all.
Her weight has nothing to do with her LDL cholesterol either. It's a very, very poor predictor. No, I'm not arguing with the glucose. I'm just pointing out that her LDL cholesterol, in terms of her coronary disease, is the biggest issue right now. She is heterozygous FH, Kim, like you said, unequivocally. Does she need to be genetically screened? I don't think so. Penny, what would be your approach here based on her LDL cholesterol, in addition to a high-dose statin, high-intensity statin, and maybe more medications? Go ahead, please.
Well, I think you have to decrease saturated fat. Target, all those nutrients that lower saturated fat. And then weight loss, too, will bring down LDL cholesterol as well. Try to incorporate good fat in her diet, like unsaturated fat, especially in places saturated. Get down total cholesterol, get down cholesterol in the diet a little bit. That has a role. Include soluble viscous fiber, like Kim had mentioned, that David Jenkins did in the portfolio diet. Mm-hmm. Those would all be, targets specifically for LDL cholesterol.
Right. What about the dietary pattern versus, say, a carbohydrate restricted pattern versus a plant-based diet? I mean, we have three different approaches here. Many of them share similarities, but they are quite different. Kim, plant-based in this woman, right?
Definitely, but I would say I think your last comment is correct, and Sarah and I will go back and forth and present different sides of the same thing: high carb versus low carb, animal versus whole food plant-based diet. But I think what we all would agree on is that refined carbohydrates are the biggest nutritional poison that is by our government, with the billions of farms or of food production subsidies. And if we could all band together on that, it would be great. But yes, I think as Dr. Kris-Etherton pointed out, portfolio would be great. A plant-based diet that gets rid of the processed food, lowers the amount of particularly saturated fat, which is obviously more dense fat than and longer chains than the polyunsaturated fats and monounsaturated fats. We could actually do a whole lot better. She is a regards trial Southern diet person, putting ham hocks and neck bones in the greens and the like. And so I would suspect that, yes, I would go for plant-based diet because I know what it's going to do for her LDL. I typically, like you saw in that analysis of diet and cholesterol, I could typically get at least 30% off with going from African-American diet to a plant-based diet. Then the statin, high dose, I get another 50%. And so then I have a handful of people who are going to need the bempedoic acid or another or something to get below the LDL of 55 that we're shooting.
One issue that comes up sometimes with all three of the dietary approaches we've shared here this morning, south side of Chicago, Kim, can she afford the type of diet we would recommend?
That's one of the most important things, and I don't usually push commercial products, and I think it is a commercial product, I'm not sure. It's a movie about African-American diet, which I found out about it when I was in French Canada. I was only an African-American in the room. It's called Invisible Vegan, and it talks about all of the historical stuff, the slave food, everything about how we got to this place of metabolic disaster in the African-American community and the food deserts and traveling long. I actually lived in downtown Detroit. I had to drive to the suburbs. And so what's happening in Inglewood, it would happen in Midtown Detroit, is that there is another commercial product that I'm not going to mention, a big chain that everybody's familiar with, decided to go in there, lower the prices, and make money hand over fist. They could lower the prices. And so a whole food plant-based diet where you're buying food in bulk, you're not buying processed stuff. I tell my patients, go to the produce aisle and don't leave until you go to the cash register. That is actually not that expensive. Compared to almost any other kind of American diet. Other than fast food, it gets pretty cheap on the front end, and then you pay for it on the other side financially.
I agree totally. I think that you can really shop on a budget with a plant-based diet, but I think people need guidance on how to do it. And I think dried beans and peas and legumes can be very inexpensive. And then people need to know how to cook with them without the ham hock and the back fat and all the sodium. So there's a lot of education that we have to do. But certainly there are ways of eating on a budget. And then I think physicians really need to play a role in arranging things for patients, helping them, i.e. food assistance programs, of which there's the SNAP program that's available to anybody who has to eat on a budget.
Well, Penny, as you recall my comment 15 years ago at the AHA. The other thing I really do in the clinic is I do a food history in terms of the quality of the diet. And I try to modify at least one component for each visit. And I think, or by phone conversation in today's telemedicine world we live in. So this is helpful. This is not a quick fix in terms of changing dietary quality. Ultimately, it takes a series of visits and steps going forward. So I'm going to turn back to you now for the second case, just because of time.
Okay. Pull this up. Okay, so patient is JM. He's a 46-year-old male, married with 2 children, 10 and 12 years old. He works as a principal at an elementary school. His wife is a 2nd grade teacher. He's diagnosed with metabolic syndrome. And here are his most recent values. Height 5'11", weight 215 pounds, BMI 30, waist circumference 41. Blood pressure is controlled on a diuretic. HDL is 35, TG is 190, LDL is 125, and fasting blood glucose is 124. Hemoglobin A1C is 7.7. Background. Well, he has a family history of overweight, obesity, and diabetes. His mother has obesity and type 2 diabetes, and his father was overweight. Father died of an MI at 64, and his mother's still living. Wife is overweight, and both children have a normal body weight. JM eats an average American diet. He enjoys eating at fast food restaurants about twice a week for lunch and about twice a week for dinner. He's pretty sedentary, likes staying up at night, watching sports events. He sleeps about 6 hours a day, and he snacks a lot on chips. And he reports being moderately stressed. He and his wife cook about 4 dinners a week, but he uses ultra-processed convenient foods to save time. So he started on his blood pressure meds in September of 2020 and was given information about a healthy diet and other lifestyle practices. His last visit was November 10th, 2020, and he indicated that he's motivated to improve his diet and become more active. So his visit today shows that he's lost 2 pounds. That's really good. He indicates that he stopped eating a mid-morning pastry, so he's cut about 400 calories during the work week, and he's replaced it with a handful of nuts, about 200 calories. So during the holidays, he let loose and really didn't worry about his diet or weight. So he needs help from the physician about other changes he can make with his diet to decrease risk factors like blood pressure, LDL, glucose, hemoglobin A1C, and he wants to lose more weight. His near-term goal is to weigh 200 pounds. And remember, he started at 215. He's lost 2 already. So he's got 18 to go. So what would you do? So my last slide is there are these 3 food-based healthy eating patterns. They're recommended by the 2020 Dietary Guidelines for Americans. And what suggestions would you make that JM could implement to decrease calories and eat more healthily, or target one of his key risk factors? Also consider physical activity. In addition, be mindful of the importance of a shared decision-making model.
Okay, Penny, a big inquiry there, and I'm going to turn to Sarah. This is JM seeing you, Sarah. Your next steps working with JM.
Well, I'll tell you what I wouldn't do. I wouldn't recommend the dietary guidelines for this patient. And that is because if you look right in the executive summary, the very first thing that they say is that the dietary guidelines for Americans are only for healthy people. And we already said that he has metabolic disease, so they're not appropriate for him. And of course, to that, we can say, they're not appropriate for most people because 88% of Americans have some form of metabolic disease, which leaves 12% for the DGAs. But that 12% gets narrowed more because if you happen to be anything but a middle to upper class Caucasian, they're not for you because that wasn't looked at in the evidence reviews. So I would definitely stay away from the DGAs. This is a perfect person for some therapeutic carbohydrate restriction. For sure, let's get rid of his metabolic disease. I mean, there's plenty of evidence that we can reverse out of diabetes, but the earlier we catch it, the easier it is. And I'll go back to that study that I had pointed out of China of how important it is, even from this metabolic syndrome, pre-diabetes state, to revert back to normal glycemia as far as long-term cardiovascular mortality goes.
So, Sarah, if you were going to approach this patient then with a carbohydrate restricted diet, again, below 25% of total calories, this wouldn't be like the induction phase of Atkins. This is not down at the level of extreme restriction, ketogenic, but more a modest carbohydrate restriction. Ultimately, what would you tell him to do in terms of the types of foods that he should eat?
Well, I would want to get to know him, and I would want to respect his ethnic and cultural background, which is not something that we tend to do. We tend to prescribe sort of, if we look at the dietary guidelines, they have Mediterranean, vegetarian. Well, what if you're Asian? What if you're American Native? We have to respect the cultural backgrounds of diets, and we need to bring that kind of into the 21st century, which is our America. America doesn't look like, a middle-class white person. It looks like a melting pot, and that the food considerations have to be accounted for.
Well, final question to you, and then I'm going to turn to Kim and Penny. So, Sarah, if you were going to implement a carb-restricted program in the clinic, would you measure beta-hydroxybutyrate to assess compliance to the program?
It depended on how low he and I decided to go together, because that would be a discussion I would certainly have and respect the patient's voice. He may opt for a low carbohydrate diet rather than a very low carbohydrate diet. And if he did, I wouldn't be checking beta hydroxybutyrate levels on him. I wouldn't expect them to be that low enough to necessarily even be useful, unless, of of course, he was doing a lot of exercise, which would be fantastic. But again, it would be a discussion that I would definitely have with the patient.
Okay, thank you. Kim, I'm going to turn to you. You're muted and we can't see you, but I'd like your comment. This is Penny's case, so we're going to come back to Penny. But Kim, your thoughts and comments about this particular patient.
So if I can just make one comment and then ask a question, and both of my comments are going to be completely different than everybody else, just because my perspective, actually, it wasn't just me, but Penny, Dr. Kris-Etherton also talked about the leading cause of death being cardiovascular disease, and pointed out it's the number one around the world. Which the other thing that we need to talk about is it's the number one in the United States, and it's the only developed country where it's still the number one cause of death. All the rest of it leading the world is because it's low and middle income countries. So we are the outlier. Okay, so coloring this case, the thing that I would do is go back to your 2013 guidelines and put him into the risk calculator. And he's going to come up pretty high. And if he doesn't go on a statin right away for that LDL of 125, you would at least want to do a coronary calcium score.
Yeah, good.
And try to, because I think cardiovascular risk is going to be his largest amount. So if I could, I know we only have just a couple of minutes left, but
for this case, yes.
So the one question that has not really been addressed that might actually help him is that we could argue back and forth about the low carb diet. This is really a question for Dr. Hallberg. But is there any place where you could do both of us? That is, do the low carb data, like the Seidelman article in Lancet Public Health, showing a benefit of a low carb diet if it was done with plant-based. Would that be good for this person?
Absolutely. I mean, and that goes back to the patient choice, right? And that's really the beauty of low carbohydrate diets is, again, when we talk about those cultural or patient preferences, you can work carbohydrate restriction into the low level and even into the very low level for any eating pattern. I mean, so for vegans, we would stay with the low carbohydrate because we need to make sure that they're getting enough. Their protein sources tend to be carbohydrate heavy, but they could do low. Vegetarians, any other cultural eating, it's very easy even to go into the very low and respect the patient's wishes. So it's very flexible. And I think that's one of the beauties of it. So but Penny, of course is my answer.
Thanks, Sarah. Penny, back to you for a final comment on your case.
Okay, so to wrap it all up and to take everybody's comments into consideration, what you could do is a lower carbohydrate to get started, healthy diet focused on plant-based foods. And then I think also what I would really pay attention to is he started to lose weight, hone in on that. He's, in the mode now. So let's get the weight down. That'll help his blood glucose levels. Two other things I think are really important. One is get rid of all those ultra processed foods where he's opening a box or a bag and adding water and heating and eating, so do some, cooking from scratch. And then forget about these fast food restaurants. He's going twice a week for lunch. He's going 3 times for dinner.
Good. Okay. Some good final comments. Third case, Sarah, you're up, please.
Right. So,
do you see your case?
Yeah, sorry. Okay, there we go.
There, good. Okay.
So here we go. This is a patient, Beverly. She is a 55-year-old white female. Weight, as you can see, high, BMI over 50. She has a 10-year history of type 2 diabetes, married, stay-at-home mom, loves to cook and bake. Very important. Remember, patient, what do they enjoy and what do they like to eat? Family history of diabetes in both parents. Father had an MI at age 60. No coronary artery disease known in the patient. She has not exercised. You can see her med list on the right. And what does that look like, to any of the physicians in our audience? It looks like every patient you see walk into your office in the med list, right? So she's kind of got it all covered. But what is the one thing that's missing there? That should be there, which of course is a statin. There's no statin. She declined to go on a statin. And we'll talk more about that in a minute. So her first visit, she's motivated because she wants to be with her grandkids. She wants off of all or most of her medication. Her blood pressure is controlled. She has no history of chronic kidney disease or elevated LFTs. Blood sugars over the last week have been 180 to 220. Recent A1C was 8.8. Her lipids are there. And what we do note is that she has atherogenic dyslipidemia, but she actually, whether you're looking at it as an LDL-C or an ApoB, her cholesterol is not bad. I mean, it could be better. But her C-reactive protein is very high. So treatment in the office, full lecture on a well-formulated ketogenic diet. I figured that is what she needed because of the long history of type 2 diabetes. There's evidence now that lower is better. We gave her access to an app and provided her with a health coach and physician oversight, which was me. She was given the tools that she needed, including a ketone monitor, because in this patient, we certainly do want to watch her ketones. And then she was given a set date to start dietary changes. And why that's really important is with a carbohydrate restricted intervention here, we're going to have need for medication drop precipitously. So we have to know exactly when they're started and give them instructions on what to do with their medication ahead of time. I told her, stop her glipizide the day she begins dietary changes. So, going through day to day, she tracked through her app, which she was able to follow her progress. Health coach worked with her on cooking and baking because we wanted to uphold her desire to do that. It fits with her family and her lifestyle. All blood pressure medications were stopped except for losartan after the first 6 months. Metformin stopped after a year. Insulin was stopped. I should have put that in there after 2 to 3 weeks. And so here's the interesting thing is here she is 5 years later, glucose, weight. And I want to go back and show what I was talking about before, which is glucose variability. Here is her CGM. She really doesn't need it, but she likes it because it helps keep her on track. And we can see we don't get the postprandial spikes. So her glucose variability is really well controlled. And here is her lipids, which were last fall, or her, labs, including lipids that were last fall, the last time we checked. And here's what we can see. Again, she's off all diabetes specific medication. She went from 8.8 to 6. I can't remember. Sorry, I can't hardly see here in my view, 6.3. And what you can see with her lipids is they look really good. And we've fixed her atherogenic dyslipidemia. Her LDL cholesterol hasn't gone up, whether you look at it as an LDL-C or you look at it as an ApoB. And so, of course, she feels better and she is doing things with her grandkids and she's still baking for them, which is really important for her lifestyle.
Well, that's great, Sarah. So, I'm not going to get into the ApoB interpretation versus the calculated LDL cholesterol, but they both show benefit. There's no question about that. So ultimately, a question to you, and then we'll open it up to Kim and Penny, is there seems to be a little weight recidivism. And I guess the question is, and you made the point that people can stick to these diets long term. That's not been my personal experience, but you showed data to confirm that. So how the more restricted a dietary program is, and it takes me back to Ornish kinds of things way back when, the people that had the ability to continue the diet did well, but there was a large amount of fallback. People could not sustain the dietary pattern. So your thoughts about the ability to sustain the ketogenic program. And I guess you did relax it maybe a little bit over time in terms of the restriction of carb, or didn't you not?
She hasn't decided she wanted to do that.
Okay.
No. No. And so I would say a couple of things about, regain is that even out again, our data to 3.5 years, there is regain, but it's quite minimal. So, they're sustaining significant weight loss. And when we look at the bariatric surgery literature, which we have to say is the most robust in this compared to any lifestyle, right? We know that there's weight regain too. And a very recent study from the bariatric literature showed that even with weight regain, even if you do have type 2 diabetes develop again once you have reversed it, that the mortality data and it stays improved in the long term. Okay. There was actually even a commentary written on this that says, have we failed with bariatric surgery because so many people are redeveloping diabetes and people are gaining weight back? And the answer when it comes to long-term outcomes is no. So there's going to be we can expect some weight gain in most people undergoing either bariatric surgery or any lifestyle intervention. But I'd say here that it's minimal overall, according to our data. When we look at even the more robust data in bariatric surgery, we feel very gratified that we're still making major impacts on their mortality.
Of course, your rationale in this woman of using the dietary approach you did was to modify cardiovascular disease risk and weight both. So you did accomplish that for sure. Kim, going to turn to you next before I turn back to Penny with some final comments here.
So I hate to be sort of break a record for sounding like a broken record, but
I think we all are kind of broken records, aren't we here?
Put her into the risk calculator, and smoking. If she is a smoker, then it's 16.3%. If she's not, turn that off, then it's 12.2%. So that means I want diagnostic studies, screening studies, and again, coronary calcium is a bit more reliable than some of the things that we do, but an ABI, give me something that says that she's not going to have a heart attack and die while we're trying to fix her diet.
Okay, good. But remember, the topic for this session is dietary quality anyway. Okay, you're done, Kim.
Thanks so much.
Okay, Penny, to you, please. And Kim, stay visual, if you will, because we're going to wrap this up in a few minutes now.
Just real quickly. No, the data that Sarah presented are very impressive. So I guess the next step that I would like to know, or what I would like to know, is what did it take? I mean, does she require a lot of intervention? How did she achieve all this? And certainly there's got to be a lot of social support as well. But
yeah, I think that's an excellent point. I mean, and one we can't understate in its importance. And she got a lot of support through, again, her health coach, and continues to do so. And, that is critical. I mean, a lot of times in any intervention, what we do is we say, oh, here's this support and we're going to do this, you group visit for X amount of time and then it's over with. Well, lifestyle changes are difficult. If they were easy, everyone would do them. Okay. And so, no matter what we're looking at, we need to make sure that we're able to support, and that's where technology can really come in. And I know we have a whole section on, on that in this conference, and how it's important, its importance and what it can bring into a team approach to healthcare, I think is vital. And if you would allow me one more comment overall here, which is, one of the things that I think is so very important is the things that we do agree on here. We agree that junk food is junky. Okay. And that we need to work harder to get it out, not just of our patient's mouth, but of our whole health food systems. Okay. So there are so many different commonplaces, and respecting the individual and realizing that there is no one size fits all is just so critical as we move forward as just a healthcare community to combat the multiple pandemics that are influencing all of us.
Great. Well, one of the issues that we face as a population, and I think it's a global issue, and Kim, other than the undeveloped world, the undeveloped world to some extent is becoming urbanized increasingly over time. But the issue is the obesity prevalence and incidence. We take care of patients who are overweight or obese to try to modify their risk. And we do it both with dietary quality, that's been the topic here, and our morning session was dietary quantity, how to best go about doing this in terms of weight reduction per se, but ultimately the prevention of obesity in a population. How do we take steps to modify this over decades? And something I reflected on over the decades gone past, is that, it took 50 years to reduce tobacco consumption from 50% of adults to, I think it's around 15 or 16% of Americans, adults, still smoke. That's 15 to 16% too many, but it's still 15 to 16% reduced from 50%. This obesity prevalence that we have, is that another 5-decade issue? And if so, can we reduce it from 42% or 41.5%, what it is in the United States, to say 15% or 20%? Your thoughts, and I think you want to think big here, pardon the pun. Penny, going to start with you on that one.
Well, I just find it so alarming. The new CDC statistics say that 74%, rounding that decimal place up, of the US population has overweight obesity. How on earth are we going to turn this around? I don't know. And I just hate to think that it's sort of a doomsday type of place that we are in right now. But I'm just really concerned about what we're going to do about that when, parents are obese, and of course their children are overweight and obese, and they're tracking in that pattern. I heard the latest statistics about longevity and lifespan. And so it's decreased by 1 year in everybody across the United States, but in African Americans, it's even more.
Yes.
They're going to live to only be about 72 or so is what the average lifespan is. So I don't know what we can do here other than education, maybe. Not sure.
Well, the cultural and ethical issues are a major issue here for sure, but it goes far past that. It really does. Kim, your thoughts? I mean, you deal, again, with a population that you've grown up in and grown from, and ultimately you're dealing with regularly in the clinic. So your thoughts?
So you've asked me to think big. And my big thoughts come from a project that my granddaughter actually started with me. We're sitting around watching stuff, and a fast food commercial comes on, and I said, the quality of food marketing in this country is atrocious. And so we actually did an analysis with one of my medical residents and my granddaughter. Mm-hmm. And what we came up with out of 104 commercials, we actually got on a website, found out what are the most frequent commercials that are done. And then we used that Jack article for healthy versus unhealthy plant-based diet that I mentioned, because yes, it had a healthy and versus unhealthy scoring system. And we scored them. And it turns out that the majority of the food that you see is from fast food, 58%, and they have a dramatically negative effect. That is, yes, the lettuce and tomato might be healthy for you, okay? But the rest of it, the refined grain in the bun, the double burger and all this stuff. And so the bottom line of this article, and I'm sure it's going through it'll be rejected from every article, like all of this. Okay.
Welcome to being an author, right?
Exactly. And so, but what we're saying is there should be legislation. That is, if they will say that we cannot market cigarettes since 1971, you can't have them on television. Okay. Why would you have something that's just as damaging and just let it go? And so I'm hoping that we can get legislation and regulation to change the food advertising. And one last comment on it is that there actually are articles written about the change with COVID, with people that there's the marketing change from your car and your airline ticket, because people weren't doing that, and started doing much more in terms of food and deliveries. And so it turns out that there are some healthy ones, and they tend to be, some of the home delivery meals, those are actually decent scoring, but the grocery stores, the individual items, they're all really bad. We need to change, particularly marketing to children, things that are harmful to their health. We've got to change it.
Thanks for those comments. Kim, Sarah, some final thoughts here, please.
Well, I agree with that completely. And, one of the other things when I think of the big picture and how do we go from here, I mean, we've got two issues. We've got to treat the people who are already sick, and we've got to prevent the disease in those who are yet to be there. And so I think that what we really want to do is start to treat the people who are already sick, because they're mostly adults. And if we can change the way that they're living, we can influence the way that their kids are being brought up. And I think that is going to be our hope.
Okay, before we depart from this session, I have a question that I want to direct to Dr. Williams. This individual asked, in a very restricted plant-based diet, are we concerned about omega-3 fatty acid deficiency, and should these people be on supplements who are on very low fat intakes and plant-based diets?
So as you know, the omega-3 fatty acid thing in cardiology blew up pretty badly. The one thing that we thought we could count on was the EPA versus DHA. There's one commercial product that seemed to have a good outcome. I wasn't really thrilled about that particular trial, the REDUCE-IT trial, because they compared with moderate dose statin, which is something we don't use. So to show them a 24% improvement in outcome after an event when high risk, it wasn't that impressive to me. And then the last big meeting came along, and there were 2 negative omega-3 supplement trials. And they said the biggest difference between them and the others, and I'd love to get your take on this, Bob, is that that one icosapentaenoic acid trial in the REDUCE-IT actually used mineral oil instead of corn oil, and the mineral oil was dyslipidemic, and that's why they showed a 24% benefit, whereas they were using corn oil and showed no benefit whatsoever. But before you answer it, I'm going to try to answer your question. Yes, that's been a big vegan versus vegan argument. And so the people in Southern California saying that if you do that that Cleveland diet, you'll end up with no heart disease and no brains. That's a little harsh, but they're saying that nuts and seeds should take care of it and recommend them highly.
Okay, that's quite good. And I think that, this session is not on dyslipidemia. That's going to be the entire afternoon, much of it. And you're welcome to join that too, Kim. But nevertheless, I think issues do come up in terms of diets that are more extreme, if you will, on one end or the other, and things we might be missing in those diets. So this is an important consideration.